pretest probability, we have suggest a specific non-invasive investigation to the patient. That is the anatomical investigation or the functional investigation. The patient who categorize on low to intermediate pretest probability, we have to advise him preferred test according to recent ESC guideline, that is the CCTA. And patient who are categorized moderate to high risk, higher pretest probability, we have to advise him as a functional categories. And third portion is dead patients who are uh, according to his pretest probability, they are categorized in a high pretest probability and they are high risk patients. So we can go directly to the invasive coronary angiography to uh, uh, they are those patients they have a very high pretest probability of vascular coronary disease, low threshold angina, and finding suggestive of low prognosis. So we have to go directly. We can go directly to investigation, that's coronary angiography. And in those other patients with the CCTA or functional pattern in which we have advised SPEC, PET, or CMR, if their findings are suggestive of high features, then we have to keep him on a medical treatment, and ultimately we have to go for invasive coronary angiography. So this is some like same mirror image of previous slide. Always we have to approach the patient according to his pretest. If patient are categorized in a very low risk, we just defer the patient advise the lifestyle modification. The patient who are in a low, a very low and low. The patients are low, we have to advise any anatomical or functional investigation according to our locality. And those patients who are categorized on the moderate to high pretest probability, we have to advise CCTA or any other functional imaging test. And fourth pattern is those patients who are moderate to high risk, who have a moderate to high pretest probability. In that patient, we have to preferred advise functional imaging pattern. That is functional imaging pattern is the PET, SPECT, CMR, and stress echo. And those are very high patient. Then in that patient, we go directly to the invasive angiography. So these are the some recommendations from the recent ESA 2024 chronic coronary syndrome guidelines. According to guidelines, we have to class one, as I have mentioned previously, class one recommendation is that we have to advise patient that test according to his likelihood of pretest probability. Okay. In symptomatic patient in home, the pretest likelihood of obstructive coronary disease by the clinical assessment is more than 5%. The patient who are categorized in the low, we can advise him CCTA, and the patient who are categorized in the low or moderate pretest likelihood, in that patient also we can advise CCTA. And number three is who are patient categorized who are low to moderate. Also in that patient, now preferred test is CCTA. Function testing is advised. That's the fifth paragraph. Function testing is advised in those patients who are categorized on a moderate to higher pretest likelihood of coronary disease. Okay. After advice, we detect the results, we get the results, and these are the high risk patient on the basis of their investigation. Those patients who have a DTS less than or equal to -5, stress or PET perfusion imaging, who involve the area of more than 10% of LE myocardium, or stress echo who have more than 3 segments of wall motion abnormality among 16, or more than 3 in Doberton stress, and CCTA involve the left ventricle disease more than 50% stenosis, 3 vessel disease, or the 2 vessel disease with involving proximal LAD or osteal LAD. They all pattern of patient are categorized as high risk. angiography is a class one recommendation. That's a new recommendation. Is we can recommend angiography if we detect any uncertainty from previous prescribed investigation. Then we can go directly for the angiography. So decision tree for a patient going for the angiography. There are two type of patients. First, patient who are very high risk, and we take them directly to the table for the case. And other patients who came to us with previously uh, uh, on the basis of their non-invasive investigations. So patient with symptoms, yes. If patient have a symptom, then uh, is there any documented ischemia? Yes, they have documented ischemia on the basis of PET, MRI. Then and we have done angiography, or if patient have a multivessel coronary disease, and multivessel coronary disease, we have to use FFR, IFR to categorize the patient's coronary artery severity. If they fall into multi severity, then we have to go for the revascularization. Uh, Otherwise, if patient have a singular disease and that is severe, we have to go further directly to the students of more than 90% are severe AFFR, IFR, and LVF 35 percent due to ischemia. Then we have to go for direct for the revascularization. And those patients who have no angina symptom, but they have a documented non-invasive high risk uh, coronary ischemic pattern. In MPS, they have a large area of ischemia, more than 10%. Are those patients who, on the basis of angiographical results, who have more than 90% diameter stenosis, are significant FFR less than 0.8%. These type of patient we can go directly for the revascularization. How will we investigate? Okay, these were the two type of patient we have. One was the lady, type A patient was the lady, and type B was male patient, was 65%. We have advised some non-invasive investigation on the basis of their clinical pretest probability, and we have these results. Type A patient, that was a lady. She has was advised for the CCTA. She has a calcium score is 0%, 0, and she is categorized in a very low pattern, and we advise her for the lifestyle modification. Other patient was male patient, 65 years. He was advised for the perfume scan, and perfume scan come to be a very high risk. They have a very high risk feature. So he has a more than 10% large area of ischemia involving hereditary, and they have a stress-induced dilatation of LV cavity. So uh, on the basis of previous ECG history, physical examination, and prescribe pretest probability, likelihood of administration, how will we will approach the patient? The step one is those patients in which we have assessed the symptom and we have performed the clinical investigation. If they fall into unstable angina ACS, then we have to go follow the ACS guidelines. The other patient who have multiple comorbidities, they cannot go for the respiration. We have to keep them on medical therapy, and then we have to be follow that patient's ECG, biochemistry, X-ray, and ecography. If they turn out to be less than 50%, then we have to categorize them as ischemic or non-ischemic. Step four is we have to assess the pretest probability and clinical likelihood of coronary disease. And we have to find that it's because of atherosclerosis or non-obstructive coronary disease. Okay. Step five is there are patients who have very low clinical likelihood of coronary disease. We in that patient we don't go for any further investigation. Just keep them on lifestyle monitoring. Okay. and other patients who are